especializado en la detección oportuna del cáncer de esófago. Tiene una formación en el Instituto Nacional de Ciencias Médicas de la India, la Universidad de Wisconsin y la Clínica Mayo. Actualmente es el presidente de la División de Gastroenterología y Hepatología de la Clínica Mayo en Arizona. Adelante, doctor. Muchas gracias.
Thank you so much for the kind invitation, my friend Jose Remes, and it's a pleasure to be here. And unlike my colleague, Dr. Layton, I think I'm regretting being in a suit. Maybe I should have been in a guayabera. So the task assigned to me is talking about understanding recent guidelines for Barrett's esophagus. It's a pleasure to be here. This is my second visit to Merida, and again, thank you so much. So in this slide, I have tried to summarize our current understanding of the Barrett's to esophageal adenocarcinoma paradigm, in which we feel that patients with risk factors, which include male gender, Caucasian race, gastroesophageal reflux, central obesity, smoking, and family history, are at risk for developing Barrett's esophagus, which then progresses through the development of dysplasia to adenocarcinoma. And we really have three tools at our disposal to alter or intervene in this natural history. The first tool is that of screening those who have risk factors for Barrett's esophagus. The second tool is surveillance in those with Barrett's esophagus to identify the presence or absence of dysplasia, and finally endoscopic therapy to interrupt or intercept this progression from Barrett's to esophageal adenocarcinoma. And in the next 15 to 20 minutes, I'm going to walk you through these interventions. So the first is diagnosis and screening. We make a diagnosis of Barrett's on the basis of two criteria. The first is an endoscopic criteria, where we ensure that we have at least 1 centimeter of columnar metaplasia in the distal esophagus, in combination with histology, which reveals the presence of intestinal metaplasia. We make this by looking at landmarks, and this is essentially, Can we play the video, please? Using endoscopic landmarks. So the first landmark is that of the diaphragmatic hiatus, and this is a video shared with me by one of my colleagues. And essentially the first landmark we use is that of the diaphragmatic pinch, and we are pulling back. The next landmark is that of the gastroesophageal junction, which typically we use as the top of the gastric folds. And then, as you can see here, we are now seeing columnar metaplasia in the esophagus. The esophagus is well cleaned. There is no residue, there is no saliva, there is no food. And we are using a high definition endoscope and slowly making our way back. And here we are coming to the top of the circumferential folds and then the top of the maximal extent. And as you can see here, we will now see the C extent, which is the circumferential extent, and then the M extent, which is the maximal extent. So what are some risk factors for Barrett's esophagus we should know of? Older age, typically age greater than the age of 50, male gender, Caucasian race, chronic reflux symptoms. We typically say at least weekly or the greater than 5 years. Prevalence in these subjects ranges anywhere from 2 to 20%. Central obesity, smoking, and a family history. So these are some of the risk factors that we should be aware of, which should make us think of Barrett's esophagus. The best way to diagnose Barrett's or to screen for Barrett's is sedated endoscopy. Unfortunately, the costs associated with Barrett's esophagus screening in the community in a randomized trial are not insignificant. And as you can see in this paper that we published, the median 30-day cost is upwards of $2,000. So sedated endoscopy is expensive, it is invasive, requires sedation, mostly physician performed, and hence there is a limitation in terms of limited access. It is unsuitable for widespread application, and only about 10 to 30% of all eligible individuals are actually getting screened. So over the last decade or so, there has been a lot of investigation in coming up with some non-endoscopic techniques to screen for Barrett's esophagus, and the technique that I would like you to be aware of is this combination of a esophageal swallowed cell collection device. There are at least 3 of these that have been studied. The first 2 are essentially a capsule with a piece of polyurethane foam that is contained inside them. The patient actually swallows the capsule. In about 5 minutes, the capsule dissolves. It releases the piece of polyurethane foam, which is then pulled out through the mouth with an associated cord or a suture. The second device is a balloon which can be swallowed and then inflated and then deflated, providing a rich cellular sample of the entire esophagus. Off of these cells, and typically these devices will yield a sample of about 3 to 5 million cells, you can then run a variety of biomarkers, and there is 2 classes of biomarkers that we should be aware of. The first is called trefoil factor 3, which is a protein marker requiring immunohistochemistry and requires a pathologist. The next is a methylated DNA marker, which can then be quantitatively assessed with a simple PCR reaction and does not have any subjective bias and can be easily scalable. So a number of investigators, including us at the Mayo Clinic, have looked at these markers, and as you can see, there is a variable sensitivity and specificity of these biomarkers for the diagnosis of Barrett's, which is typically done with an endoscopy, and this can, however, be done by a nurse in the office in less than 10 minutes. Indeed, in the most recent ACG guidelines, in addition to endoscopy, we are now recommending a non-endoscopic swallowable esophageal cell collection device combined with a biomarker as an alternative to sedated endoscopy for screening of Barrett's esophagus. One of these technologies is commercially available in the United States, and the other one is likely going to be launched by Exact Sciences as a test in the next year or so. Now, once you have Barrett's esophagus diagnosed, you should then be conducting surveillance and reporting the Barrett's length in a very standardized manner. This is where the Prague classification comes in, and as I showed you in the video, we typically will report not only the maximal length but also the circumferential length. Once you have Barrett's diagnosed, you want to put your patient into endoscopic surveillance. Remember, this is the second step to accelerate the diagnosis of dysplasia in these patients, and we all should be standardizing our methods, and a few principles need to be followed. The first principle is really to look more and biopsy less. As I showed you in the video, you should be washing the mucosa to clear it of mucus and secretions. You can use a simethicone solution. You can use a soft cap to fix the mucosa, fix the focal length, and expose any subtle lesions, and universally use high-resolution white light endoscopy and some kind of electronic chromoendoscopy, which you should be comfortable with. And again, as I showed you in the video, please use a systematic examination. I typically like to examine the Barrett segment from distal to proximal. Avoid overinflation, because overinflation will make you miss subtle lesions. As you can see in this picture on the right-hand side, if you deflate the Barrett segment, you will pick up subtle lesions. Always inspect not only in the antegrade position but also in the retrograde position, because sometimes in the retrograde position you will actually see a subtle lesion pop up because you can see the G junction on an en-face view on the retrograde position. Allow adequate time, just like we just talked about. There is the withdrawal time, and now there is increasingly the concept of Barrett's inspection time that is being discussed, because studies have shown that the longer you inspect, the higher the rate of detection of visible lesions and high-grade dysplasia. You should be using some kind of chromoendoscopy imaging techniques, and these can be divided into wide field, where you're really looking at the entire Barrett's mucosa, sort of looking at the entire forest. And here, typically, you can use either optical chromoendoscopy or digital chromoendoscopy. And this really depends on the platform of the endoscope that you have. Olympus will have narrowband imaging, Fujinon will have blue light imaging, and Pentax will have iScan or OE. You can also then use magnification endoscopy if available, sort of looking at a narrow field imaging where you're really looking at smaller areas, or sort of like the trees on the endoscopy. It is important to know that using electronic chromoendoscopy or even chromoendoscopy will substantially increase the yield of dysplasia. And this was a systematic review and meta-analysis published more than 10 years, that if you consistently use electronic or chromoendoscopy, your dysplasia yield will increase by 35%. So again, this is something that we all should be using. Of course, in addition to how to look, we also need to be aware of what to look for. And I think none of us are going to miss prominent findings such as these, which can be elevated or depressed lesions. But importantly, it is crucial for us to remember that subtle findings are much more common as a manifestation of dysplasia in patients with Barrett's. As you can see, these are subtle findings on white light and narrowband imaging. So the most recent Barrett's esophagus guidelines from the American College do suggest that surveillance should be conducted with high-resolution endoscope and high-definition monitors using electronic chromoendoscopy. Make sure that you sample the visible abnormalities separately, and also perform surveillance biopsy every 4-quadrant, 1 to 2 centimeters. And this is a picture that I have taken from the AGA, and it is also important to confirm dysplasia with the GI pathologist. Why is this important? Because progression risk in Barrett's esophagus as well as management is really dependent on the grade of dysplasia. As you can see, patients with no dysplasia progress at a lower rate compared to patients with high-grade dysplasia who progress at a much higher rate, almost 20-fold higher, and patients with low-grade dysplasia will progress at a rate that is intermediate between no dysplasia and low-grade dysplasia. And hence, it is critical that we identify the grade of dysplasia. So patients with no dysplasia, we would recommend surveillance, whereas those with high-grade and low-grade dysplasia, we would recommend endoscopic eradication therapy. It is also important to remember that there are some other factors such as older age, male gender, and smoking, which also predict the risk of progression in patients with Barrett's esophagus. How often to perform surveillance? So for the first time in the current ACG guidelines, we have suggested that patients who have no dysplasia but have short segment Barrett's, you should be surveying every 5 years. In those who have no dysplasia but long segment Barrett's, you should be surveying every 3 years. If you have someone with indefinite dysplasia, any length, you should be repeating an endoscopy within 6 months after increasing the proton pump inhibitor to twice-a-day dosing, and then, of course, follow the recommendations of the grade of dysplasia on the next endoscopy in 6 months. If someone with low-grade dysplasia wants to follow with endoscopic surveillance, that is also reasonable. You should bring them back for an endoscopy at 6 months and then follow them every 12 months thereafter. Let's move to the last principle of management in Barrett's esophagus, which is endoscopic therapy, and this typically will be done in patients with low or high-grade dysplasia. The components are as follows. The first is detection and staging, as I talked to you about on endoscopic surveillance. The next is tissue acquisition with endoscopic resection. The next step is elimination of intestinal metaplasia with ablation. And of course, once you have successfully ablated and removed all intestinal metaplasia, you should be then doing post-ablation surveillance. Why should we be doing endoscopic resection? This is most important for accurate histologic staging, because when we perform endoscopic resection, we can upstage histology, so from low to high grade or from high grade to cancer, in about 30% or more of cases. Pathologists are also not surprisingly able to give us a better read of the grade of dysplasia. And of course, this is critical for the staging of patients with T1 cancer, because endoscopic resection will give you a better staging of the depth of invasion than endoscopic ultrasound, and also allow us to identify prognostic variables such as lymphovascular invasion and deep margin positivity. So endoscopic resection allows us to perform and choose appropriate endoscopic therapy or esophagectomy as the treatment. So how can we perform endoscopic resection? We essentially identify the lesion, we inject submucosally and lift the lesion off of the muscularis propria and then resect the lesion. This can be done with cap-assisted endoscopic resection using stiff endoscopic caps and a crescent snare, and this could be done with the Olympus device with a single resection per snare. On the other hand, more commonly, we are now using band ligation, which allows us to perform 6 resections using a banding device and a hexagonal snare. And as you can see, you can resect a large area of the esophagus. Now, more recently, we have started using endoscopic submucosal dissection, where you can inject and lift the lesion, but instead of using a cap, you can now use a variety of endoscopic knives to make an incision, dissect in the submucosal plane, and remove a larger lesion en bloc. Following endoscopic resection, we can then proceed with endoscopic ablation. The most common technique is radiofrequency ablation, and as you can see from 2 large multi-center trials performed in the United States and Europe for high-grade and low-grade dysplasia, we have now shown conclusively that if you ablate endoscopically in patients with low and high-grade dysplasia, you can reduce adenocarcinoma risk. So what do we suggest in the most recent American College of Gastroenterology guidelines? We suggest initial endoscopic resection of all visible lesions, followed by endoscopic therapy with ablation in those with confirmed low and high-grade dysplasia or intramucosal cancer. We typically will go for radiofrequency ablation, which is the most well-studied and has level 1 evidence. Radiofrequency ablation is a thermal contact ablation device which is available in both circumferential and focal modalities. I believe it is also available in Mexico. A newer technique is cryotherapy, which can be done with spray cryotherapy using liquid nitrogen devices. This is the spray cryotherapy device requires a large console, a decompression device. You can spray the Barrett's mucosa with the liquid nitrogen, which is delivered through a catheter. Again, this, as I said, requires a decompression catheter, and in terms of efficacy has 80% removing of dysplasia and 60% removal of intestinal metaplasia. Challenges are visibility. The other technique is balloon cryotherapy. This is a newer technique which allows us to use liquid nitrous oxide. It actually has a balloon with a rotating diffuser, and you can actually put this through the biopsy channel of a therapeutic device and treat shorter segments, and the initial data is very promising. So in summary, Barrett's diagnosis and screening requires careful identification of landmarks. Avoid biopsying an irregular Z-line unless you see at least a centimeter of metaplasia in the tubular esophagus, and consider screening in those with multiple risk factors. Non-endoscopic screening is on the horizon. For Barrett surveillance, make sure you clean the mucosa, sample adequately, and follow guidelines for surveillance. And of course, for therapy, endoscopic resection is critical, followed by ablation, and achieve complete remission of intestinal metaplasia. Thank you so much.